Good day, my dear. Okay, very good. Amrit. Good day, my dear postgraduate students. Welcome to Glide the Slide. The series that I have taken up shall be a slide with a history. In fact, there are some arrows pointing to the lesion whatsoever. But what is expected of us is to know the contents rather than to possess it. This is a tissue from a 32-year-old female with an ill-defined mass in the right breast. Look at the age, 32 years, ill-defined mass, right breast. And what are you people seeing on the screen? I hope you people are able to make out something. Now, what are the features and the definition of this particular lesion? It is a lobulocentric granulomatous inflammation. Please be careful. The term granulomatous inflammation is very vague. And the diagnosis is one of exclusion rather than confirmation. There are other terminologies such as idiopathic granulomatous mastitis or the lobulogranulomatous mastitis. And these two are my references in this particular presentation. One is Ackerman, the other one is pathology outlines. The details are given over here. This is yet another slide we shall be seeing. Try to concentrate on the slide and note down what all you can find. In the meantime, I shall go on to the theoretical part of it. It is a rare, benign, inflammatory process affecting women in the childbearing age group. That is why a history of 32 years has been given. The clinical symptoms and radiological findings, however, can mimic that of carcinoma breast. It is associated with pregnancy lactation, oral contraceptive pill, hyperprolactinemia, and autoimmunity. So here also I am able to find a lesion and it is surrounded by some cells. We shall see it in a better magnification. So it is a lobulocentric granulomatous inflammation and the etiological diagnosis is one through exclusion. Look at this picture again, it's the same. So I am finding a central granuloma composed of histiocytes and maybe even epithelioid-like cells. And I'm able to see a good number of these dark cells, the lymphocytes in the periphery. The white arrow points out to a giant cell. It can either be a foreign body type of a giant cell or sometimes, to confuse us further, it can be a Langhans type of giant cell. So we are seeing the three things. This looks more like a foreign body, whereas this looks like a Langhans. Sucus. This is a Langhans giant cell that I am seeing. Courtesy pathology outlines. It is a rare lesion, more common in the paras, that is the reproductive age group, childbearing women. Frequent in the postpartum, not postmortem. Postpartum and breastfeeding women. And the median age is around 30 years. In our history, it is 32. Look at this. I am able to find multiple, rather well-defined lesions, which are dark and are composed of large cells, which I can see. Let me go to a higher magnification, if you can see it better. Okay. There are some slipper-shaped nuclei. Probably they are epithelioid cells. Plasma cells are present, and also there are a good number of lymphocytes. And intervening is a loose fibroconnective tissue that I am seeing. In the breast, it is usually unilateral and the pathology is of unknown origin, unless it is proved otherwise. The problem is it mimics a cancer, including inflammatory breast cancer. It can be a palpable mass presenting with pain. Pain can be a clue over here because generally my professor used to say, absence of pain is an ominous sign, suspicious of malignancy. In addition to it, there can be the formation of abscess and a fistula. Nipple retraction can be there to confuse us further. and the pure orange. Rarely there is a lymphadenopathy. That is a blessing in disguise. So this is the clinical picture of it. And this is probably they have drained something or taken a biopsy out and then the lesion is persistent or recurrent. This is another picture. I think the granuloma is very well brought out over here. In addition, I am able to find some glandular elements or ductular elements to confirm that it is a breast tissue. And there are the various types of giant cells which are present, the adipocytes over here and the connective tissue. But what can be the differential diagnosis? It is not easy for us to see a granuloma and get away with it. For this, I would like you people to kindly see. So this is the gross picture, courtesy ResearchGate. It can be a great and firm mass, about 5 to 6 centimeters and ill-defined, or it can have subtle nodularity. These are some examples. Thanks to this reference. And this is the differential diagnosis. Cystic neutrophilic granulomatous mastitis. Small cystic spaces with neutrophils. Granulomatous mastitis due to infection. We should be able to identify the fungi or the bacteria, that is the etiology of it. Tuberculous, necrotizing granuloma as at first stage. Foreign body granuloma will be having the foreign body type of giant cells. Sarcoidosis, granuloma not confined to the lobules. If you are lucky enough, you will be able to see the asteroid and the Sherman bodies. Small, squamous metaplasia of the lactiferous ducts. That can be one. And IG4 related sclerosing mastitis. This has got a storiform fibrotic pattern along with pustules. So this can be the list of differential diagnosis, and your diagnosis is granulomatous mastitis. I am now harping on the non-neoplastic lesions of the breast. What next? We shall see in next class.